சுத்தமா என்ன நிரப்ப முடியும்
ஒன்றாடி
I am very sure every speaker will fix to their time given. 8 minutes presentation, 2 minutes question and answer. That happens, probably we will get all the 8 topics. Unfortunately, Dr. Vijay Chandrappa is involved in an emergency case in Davangere. He is not able to come. So one batsman is out already. So our job also becomes easy now. And to make things better, who cannot attend this conference or the CME, there is a live stream going on. So all the peripheral doctors, whenever they are invited, they told, no, it will not be possible to come on our own personal reasons. So we thought of doing a live stream arrangement. So it's happening in the YouTube. If somebody wants to send to your friends, ask the link from our marketing team and send across, please, so that they also can enjoy this scientific feast. So without wasting much time, let us start the event with the opening batsman, Dr. Shivraj Absalpur from Davangere. He is a gastroenterologist. And also, I request Dr. Nischal, oncosurgeon from Davangere, to chair this session. Dr. Shivraj, please.
Sunny lights.
Thanks.
Good
evening, everyone. So I welcome you all for this unique CME with a topic titled around interesting clinical case scenarios. So the first speaker of today's evening will be Dr. Shivraj. He is a medical gastroenterologist in Nanjappa hospitals. Without much delay, we will start with the presentation regarding management, one of mode of management of hepatitis.
Good evening, everyone. Firstly, I thank physical case on difficult CBD stones. Symptomatic gallstones. They usually present with pain, abdomen, jaundice, cholangitis, acute pancreatitis, or asymptomatic elevation of liver enzymes. They can be of two types. We call it as DNO when the stone is within the intrahepatic or extrahepatic bile duct, or we can call it as secondary stones when they originate from the gallbladder and migrate into the bile duct. So, diagnosis initially ultrasonography was thought to be the gold standard because it's cheap, widely available, safe. So still it is considered as best initial modality, but the thing is we can miss distal CBD stones and small stones. Endosonography, which is the latest modality where we do endoscopy plus sonography in a single setting. It has got very high sensitivity. It is, in comparison to MRCP, it is very useful in patients with claustrophobia or metal clips where we cannot do MRCP. Both US and ERCP can be performed in a single setting in the same anesthesia, so this is the advantage. The other modality is MRCP, which is nothing but a T2-weighted scan sequence of MRI. Compared to US, it is widely available, minimally invasive. It has got ability to image the intrahepatic ducts much more better than US, cost effective, and it is suitable in altered now. So, if you ask me which is the best modality, MRCP versus US, we recently did a meta-analysis of comparing MRCP versus US for diagnosis of cholelithiasis. We found that both are equally good modalities, whereas US carries slightly better sensitivity, specificity, and accuracy in comparison to MRCP. So, common indications for ERCP are bile duct stones and cholangitis. Other indications are strictures, chronic pancreatitis, bile leak, and post-liver transplant strictures. So this is the topic. Before I go to the case, What is different CVD stone? It is characterized by stone with size of more than 15 millimeter, barrel or square-shaped stone, or multiple stones more than 3 in number, intrahepatic or cystic duct location, narrowing of bile duct distant to the stone, periampulate diameter and duodenal structure. So usually these big stones or difficult CVD stones present with cholangitis. There is always a dilemma: what should be the timing of ERCP in those patients, whether early or delayed. There is an interesting article where they have found that when they studied the outcomes and predictors of delayed endoscopic biliary drainage for severe acute cholangitis in patients with choledocholithiasis admitted in ICU, they found that delayed ERCP for patients with severe acute cholangitis has got high mortality rate and prolonged ICU and hospital stay. So we reviewed the topic recently and we found that there is no consensus on what is delay. I mean, how much delay is called as delay. But we found that delayed drainage is mainly due to cardiac arrhythmias, liver disease, coagulopathy, elevated creatinine level, and WBC count at baseline, maybe high or low. So this is a cholangioscope system. Initially, when the cholangioscope was introduced, it was a dual operator system, where mother-baby system used to call, where two operators are required to operate this. Now, Boston Scientific has introduced a single operator cholangioscopy system, where it enables us the direct visualization of the biliary system, and it carries a 10 French catheter, which can be introduced through the channel of the ERCP scope, and this contains a fiber optic probe, which helps in higher image resolution and wider field of view. And through the tip of the cholangioscope, the accessories can be passed like a spy bite or a spy basket. So this is a cholangioscope which with the cholangioscope, the probe of the cholangioscope can pass through the tip of the working channel of the ERCP. So this duodenoscope, once it passes the esophagus, the stomach, and reaches the small intestine, through the side view, the channel, the spy scope DS catheter passes and it enters the bile duct, and it can be introduced up to the hepatic duct. You can see it is being introduced in one of the branches of the hepatic duct. You can see all the branches of the hepatic duct, visualize it, and then the other advantage of this spy scope is all the debris, mucosa, and all the secretions can be cleared with the irrigation suction method, which is available at the tip of the probe. And also you can see the suspected lesion which is present in the wall of the bile duct. With this suspected lesion, we can take the specific targeted biopsies also. And other use of this cholangioscope is, if there is a very big stone or large stone, we can pass the laser probe through the spy scope, and the stones can also be broken. So this is a case capsule. This was encountered in my previous institute, where there was 27-year-old lady presented with right upper quadrant pain with fever for 3 days. General physical examination was normal except interest. Systemic examination was also normal except there was a mild tenderness in the right upper quadrant. And LFT was showed predominant direct bilirubin with elevated AST, ALT, ALP levels. MRCP shows two stones, one in the distal bile duct and another in the right hepatic duct. The distal bile duct stone was removed with a routine maneuver, and I'll show the video, please. Can you please play the video? Can you please play the video? So selective bile duct cannulation was done. This is the duodenum part, and this is the cannula which is passed. Now biliary sphincterotomy is being done up to the fold of the duodenum at 11 o'clock position. And once this sphincterotomy is done, we usually pass the cholangioscope. So once the spinous cholangioscope is inserted, we get the internal view of the bile duct. So this is the bile duct view and this is the duodenal view. So cholangioscope can be advanced up to the hepatic duct, as I have told you. So stone was sitting in one of the branches of the hepatic duct here. So we could reinsert the guide wire, reposition it towards the desired duct, and then over the guide wire we pass the spy basket. And once the spy basket is passed, it is opened, and then the stone is cast. Once the spy basket holds the stone tightly, we can pull out the stone under the cholangioscopic guidance. So now the stone is being pulled out under the cholangioscopic guidance. And this is the spy basket with stone after extraction. So this was published in a very reputed journal of endoscopy in 2022. So this novel technique of spy basket guided pilot stone extraction, there are very few case series in India. This article is still in under test being published. We have a case series of 10 patients, 80% female, 20% male, with a mean stone size of 12. The unique feature of this is we can do the ERCP with radiation-free extraction, and especially helpful in young female or pregnant women. So the last modality for different CT stone is laser lithotripsy. Again, this is our previous center experience where in a duration of 30 months, 764 patients presented with CT stones, and among them 89% of the stones were removed by standard techniques and 8.8% stones were removed using cholangioscopy. So the complete ductal clearance was achieved in 91% of the patients. So the take-home message is different CT stone accounts to 10 to 15% of the patients with CT stones, and the stone extraction using standard techniques is challenging in these patients. So cholangioscopy offers a direct visualization of the bleed ductal system. So ductal clearance with spy basket and laser lithotripsy are the novel methods. Thank you.
Thank you, Dr. Shivraj. Any questions from the audience? I think there are no questions. So, thanks to Dr. Shivraj for sensitizing us regarding one of the novel techniques of managing this really difficult CT stones and appendicitis process. Thank you once again.
I'm very happy to announce about Dr. Shivraj's. As everybody knows, every year API releases update books. This year's update contains one chapter from Shivraj. I think it's a pride moment for the institution. I also want to announce that Dr. P.K. Pai, our beloved physician from our group, also has published a chapter on KFD. And last year, Dr. Srikanth Hegde also has contributed a chapter for artificial intelligence. These are all the pride moments in our profession. I think it's right time to express it and share the happiness. Now, second topic, as I told earlier, it is dropped out because of Dr. Vijay Chandrapur could not join here. Now we go to the straight third topic, or the case presentation from Dr. Ganesh Gowda from again neurology. Dr. Ganesh, please, and I request Dr. P.K. Pai.
So let us not waste time. I request Dr. Ganesh to start this.
Myself, Dr. Ganesh, neurologist at Nanjappa Hospital, Nanjappa. Today I am going to present an interesting case. Here is a patient, 70-year-old male, presented with complaints of burning sensation, tingling paresthesia in all the limbs since 4 weeks, and involuntary muscular movements in all the limbs, sleep disturbances, and imbalance while walking. All these paresthesias initially started distally. Over a period of 2 weeks, has progressed to involve all parts of the body. This was continuous, and there are no aggravating or relieving factor. Patient also complaining of pain, burning sensation, and cardiac sensation in the feet and hand. And patient was complaining also difficulty in walking in the form of swaying on either side. It used to worsen during the evening and on the eyes closure. That suggests a wash basin phenomenon. And history of involuntary muscular movements in the form of twitches, worm-like movements, and cramps initially started in the calf. Over a period of 2 to 3 days, it progressed to involve all parts of the body, and even it present at rest and sleep. And some features of autonomic nervous system involvement in the form of sweating, palpitations, urgency, frequency of urination, and patient having also difficulty in sleep in the form of inability to initiate and maintain the sleep in the form of insomnia, and one episode of generalized tonic-clonic seizure during the hospital stay. Other than that, no other neurological complaints and no systemic complaints. And patient is now in case of diabetic hypertension and CAD. He underwent PTCA 3 years back. And 3 months back, patient had a left MCA territory infarct. For that, he took herbal medications over a period of 2 months. Details of the medicines are not available. Let us come into the analysis of symptoms. First one, that burning sensation, tingling, paresthesia, and sensory ataxia. It indicates involvement of both small and large fiber nerves, that is peripheral nerve involvement. Pictures in the form of random pictures in fasciculations and undulating worm-like movements of myasthenia and associated pain that sense of cramps. It indirectly indicates the peripheral nerve hyperexcitability, that is motor unit. And third one is seizures. Details of the seizure is not known. It indicates the involvement of cerebral cortex or any metabolic abnormalities. And fourth symptom was the sleep disturbances in the form of acute insomnia. Neurological localization involves the thalamus or pontine perilogus or autonomic nervous system involvement. Overall, patient having peripheral hyperexcitability in the form of myasthenia, twitches, and seizures and sleep disturbances indicating the central nervous system involvement and autonomic symptoms. So indicates both peripheral and central hyperexcitability features. We put the differential diagnosis, that is toxic neuropathy, in view of history of 2 months intake of herbal medicines. And elderly male subacute onset, again one of the differential is paraneoplastic encephalomyeloneuropathies. Third one is peripheral hyperexcitability syndromes like ISAC syndrome, Morvan syndrome. And fourth one is secondary motor neuron diseases, commonly seen in hyperthyroidism, hypo and hyperparathyroidism, lipomas, myeloma, anti-WHO, antibody-mediated paraneoplastic motor neuron disease, or HIV. Some points like differential diagnosis, toxic neuropathy, the features which in favor were painful neuropathy, CNS features, myotonia, and history of Ayurvedic medicine exposure. The points against for the toxic neuropathy were there was no temporal correlation. Even after stopping the herbal medicine, patients still having the symptoms. And second one is motor neuron disease, that is amyotrophic lateral sclerosis. Patient having hyperexcitability, myasthenia were in favor of motor neuron disease, but the associated sleep disturbances, absence of atrophy, weakness, rapid progression, sensory loss, and urinary complaints were odd to the motor neuron disease. Third one is paraneoplastic encephalomyeloneuropathy, that is anti-WHO, antibody-mediated paraneoplastic neuropathies. All features were looking in favor of paraneoplastic, but there were no systemic symptoms like fever, loss of weight, or appetite. Last one is Morvan syndrome, that is peripheral hyperexcitability syndrome. All features were fit into the painful neuropathy, sleep disturbances, and autonomic features. In view that we evaluated. And general physical examination, patient was having autonomic features like diaphoresis, resting tachycardia, and cognitive impairment in the form of attention and concentration deficits. And seventh nerve facial palsy was there. Bilateral element type of facial palsy was there. There were tongue fasciculation. And examination, patient was having hypotonia and hyporeflexia all the limbs. And examination of the calf and thigh muscle suggestive of random undulating twitches and worm-like movements involving the thigh, calf, triceps muscles, face, back continuously, even presented rest and sleep also. That was suggestive of fasciculation and myokinias. Sensory examination, there was involvement of peripheral nerve in the form of impaired pain and touch sensation till ankle, till knee in the lower limb, and till elbow in the upper limb, and there were impairment of joint position, vibration also. Rampart test was positive. Can you? In the third, patient having pixels and worm-like movements. These are the myokinias, predominantly involving calf muscles. and twitches that involve in the small muscles of the joint that are causing the movement of the joint, that is polymyelitis involving both the upper limbs. And same fasciculations in the arm. Involving both biceps and triceps muscles. And patient was having sensory ataxia, white-based gaze, needs one person support for his routine activities of daily living. Summary: elderly male presented with subacute onset paresthesias, numbness, sensory ataxia, acute insomnia, seizures, myokemia, fasciculations and cramps, and examinations involvement of autonomic nervous system involvement, frontal lobe, attention deficit. Then in favors of both peripheral and central hyperexcitability syndrome. In that we evaluated, routine investigations were normal, viral markers negative, and patient was not willing for heavy metal screening. Thyroid, parathyroid screening was normal. ECG, urine benzone protein, echo, EEG, MRI normal. Sleep study not done. CSF analysis was normal. Nerve conduction study suggestive of sensory motor axonal neuropathy with repetitive CME. An EMG study, can you play the video? Sound. EMG suggestion of neurogenic pattern, frequent fasciculation, doublet, triplet, myokemic discharges were present. Sound. These fasciculations of myokemia, cramp discharges usually originate from the motor unit, predominantly from the axons. Later we evaluated for the autoimmune panel, suggestion of Caspar-2 antibody was strongly positive. The Caspar-2 is the contacting associated protein which is surrounding the axon, which usually regulate the neuronal hyperexcitability. If any mutations or any antibodies produced against the Caspar-2 antibodies, that will result to peripheral hyperexcitability. So Caspar-2 antibody was strongly positive, and rest of the exam like panel was negative. CT chest and abdomen was normal. Due to uncontrolled sugar, we could not able to do PET scan. In view of acquired peripheral hyperexcitability with CNS and autonomic nervous involvement associated with a strong Caspar-2 antibody positive, we made the diagnosis of Moore syndrome. In view of recent myocardial infarction and ischemic heart disease, IVIs were not given. Patient was given 5 cycles of plasma exchange after along with the steroids and pregabalin. After the treatment, patient's sleep, neuropathic pain, and myokemia was improved. Let us come to brief about Moore syndrome. It is an autoimmune condition affecting the different part of the neuroaxis, characterized by peripheral nerve hyperexcitability, dysautonomia, encephalopathy, hyperhidrosis, hallucination, amnesia, insomnia. Usually MRI brain will be normal, and VGPCs, Caspar-2, LGI1 antibodies will be positive. It commonly associated with CLN, thymoma, and myasthenia gravis. There are 3 spectrums of peripheral nerve hyperexcitability syndrome, that is cramp fasciculation syndrome, ISAR syndrome, and Moore syndrome. Mainly treatment will be membrane stabilizing agents like carbamazepine, oxcarbamazepine, along with the steroid, IVIG, or in combination. And for steroid sparing agent, we can use cyclophosphamide, azathioprine, or cyclosporine, or rituximab. Some data regarding the antibodies. Usually paramyoplastic autoimmune antibodies, they are classified as high risk, intermediate risk, and low risk antibodies. If high risk antibodies will be associated with more than 70% of the patient, those who having the cancer. And most of the paramyoplastic antibodies will present earlier to the onset of the cancer. That around 60% of patients, even they present earlier to the onset of the malignancy, and 35% of the patient along with the malignancy, and 5% of the patient will present after the diagnosis after treatment of malignancy. And till now there are 50 case reports are documented as per to antibody related. And the prevalence of antibodies varies from cancer to cancer. Overall estimated incidence will be 0.5 to 1% of all the patients with cancer have clinically disabling paraneoplastic syndrome. But however, in neuroblastoma, small cell carcinoma lung and thymoma, sclerotic myeloma have high incidence of paraneoplastic syndrome. That is from 2 to 3% to 50% of the patients. Prognosis, efficacy of therapy is mainly assessed by the monitoring of clinical response, and electrodiagnosis can be useful in monitoring, and needle EMG by observing the reduction of the cramps or fasciculation we can assess the prognosis. Serial quantitative measurement of neuronal ion channel antibodies may be helpful in monitoring the disease progression and response to immune therapy. Take home message: elderly, subacute onset cognitive decline, seizures, insomnia, cramps, myopia. Don't forget to evaluate VCTC antibodies. All fasciculations are not belongs to motor neuron disease spectrum disorder, and all cases are not fasciculation. General physical examination should not be neglected. Early detection and treatment will have good neurological outcome. Tumors may present up to 4 years after the onset of peripheral hyperactivity, so vigilance is mandated. One more note: all fasciculations are not belong to MND spectrum disorders because fasciculation can be originated from the anteavanal, motor nerve root, cervical plexus, nerves, myoneural junction, or muscles. Thank you.
That is an interesting case. So, I have to say, I invite any questions from the audience.
How long you will need treatment?
So every 6 months we need to, if patient diagnosed have any cancer, like most commonly it associated with CA lung or thymoma, if we get that cancer, if we
toxic neuropathy.
yes, sir.
Actually, you have not done
Yes, sir.
environmental screening.
They are not willing, sir, actually.
In Bangalore, 1 or 2 centers, they do screening at every center.
No.
Castor antibodies being positive goes against the toxic neuropathy, isn't it?
Yes, no, that goes against toxic neuropathy. But I went through some of the literature, even toxins also associated with Castor to antibodies. No? That I insisted attenders to get it done. If they get it done, we'll treat accordingly.
The background of the cancer antibodies.
Yes, sir.
Doesn't mean that you should not take heavy metals.
Yes, sir.
They could have taken heavy metals. On top of it, probably that could have triggered.
2 cases, 2 etiology might be there. Sir.
That could have caused that. You should not put a
And
blind.
even after plasma exchange, patient not improved well. Sir. Usually after 5 exchange, patient should be normal, sir. But improvement is not up to the point. In thinking of 2 etiologies in this patient, working for that. Thank you.
Thanks.
DM neurology case, probably anybody can fail a candidate with such a case which involves from hair center to the last part of the central nervous system. Very nice presentation. Thanks, Ganesh. We will go to the third presentation. Again, another challenging, and since the intensivist involved also young, I think he has made huge contribution for this case, but I don't forget the team. This case is admitted in Nanjappa Life Care. If at all, if I remember any teamwork for a patient who is supposed to be declared as dead, is walked out and he is in resort today because of the wonderful team. I think I saw it, their presentation. I now call upon Dr. Arjun Ennor to present case of complicated intra-abdominal infection. And for next two topics, I request Dr. Rakesh to chair this session, please. Arjun.
I'm a consultant working in Nanjappa Life Care. This patient, unfortunately, adhere to that what we have treated in aspects of like antibiotics and what are the organisms we got through and how we dealt with all those organisms and what is the evidence behind treating that case. So let's go with the case history. So this was a elderly male who is a 61-year-old and a known case of hypertension. He was having a recurrent anemia. So he went to Bangalore for the evaluation, and in the routine endoscopy they found out there were multiple bleeding gastric polyps, and the biopsy even showed a high-grade dysplasia. So when the patient was convinced to go for a surgery, that was a total gastrectomy, which was an elective procedure, and he went and had a esophageal digenostomy and feeding digenostomy along with that. And the procedure got over on 15/4, which was uneventful. The following are the sequences which I just highlight. The other things we will just not take at this time. The first important thing persistent to his infection was in the second post-operative day, that was in the center where he was operated. He stayed in an ICU. There he developed fever, and the blood cultures were showing the gram-negative bacilli. And in the post-operative, observed discharge from the surgical wound, and there was a dehiscence probably. The stoma bag was applied and it was draining. He was treated with meropenem and amikacin for a period of 1 week, and he was unevaluated why the GMB has come. And the patient became afebrile after 24 hours of starting meropenem and was discharged on day 7. With this, the patient has reached back his home in Birur. In the same night, the patient has developed a respiratory distress followed by profuse sweating, and the whole body went into a cold state. So with this, the patient attendants rushed to a local hospital in Birur, where he was treated in ICU, and we don't have any records pertaining to that. He was probably treated for a period of 6 hours, and after that, the attendants were not convinced with the treatment, so they got to our center. And on arrival to the casualty on 22nd, so almost in the afternoon time, the patient was having a frank sepsis. So his respiratory rate was very high, his heart rate was high, he was having a obtundation, there was a soakage and drainage of pus and the lap incision site, and his systemic examination, everything was normal. In the sense, respiratory had some nasal decrease sounds. So we quickly did a point of care ultrasound, and we ruled out the other causes of hypotension. So we finally ended up with a diagnosis of sepsis with shock, and we gave a loading dose of meropenem as infusion and tetracycline. So it was a sepsis with shock. The rest of the management we did along with the surviving sepsis guidelines. According to the latest evidence, the patient was intubated, started on IV fluids, inotropes, and the rest of the things. We also got a quick CT scan done. It showed an anastomotic leak. So all the ICU scoring systems which we routinely do in our ICU on admission was showing a mortality which was greater than 50% in this case. So in the next 6 hours, the patient general condition deteriorated. He was on triple inotropes and a stress dose of steroid. We even added polymyxin B along with ticoplanin and fluconazole for the candida. So in the first 6 hours only, patient had anuric and he was acidotic too. So we initiated CRRT, and in the patient general condition, the next 24 hours deteriorated, and many times we have seen the BP crashed between 40 and 60 systolic, and the patient was also resuscitated with IV fluids and IV albumin just to keep him alive. So in the day of admission, I just concentrate on the infectious markers. The total count was 24,000, the procal was high, the creat was high, and the NLR ratio was high. So what we were dealing with at that point of the time was probably a gram-negative sepsis, as the blood had already grown GNB on the second post-operative day in the previous hospital, and the source control was not done. So the source being the abdomen anastomotic leak and sepsis with severe shock along with that MOTS. So what empirical antibiotics are we going to treat this patient? So we quickly go through this IDSA guidelines, this is the Infectious Disease Society of America guidelines, followed by the WSES, both of the guidelines, what it suggests. So that patients who comes with an intra-abdominal infection, the first thing to be done is a source control, which was not done in this case in the previous hospital. And the empirical antibiotic therapy, it depends on the local epidemiology and individual risk factors has to be determined whether it is a case of MDR. And it has a clinical severity. Fluid support, which started microbiology culture, present vasopressors we have administered, and we have to reassess whether again the antibiotics has to be brought in. So the next thing, in this case, they also say this is a case of high mortality. Most common cause of post-op peritonitis is anastomotic leak. The infection acquired, especially in such cases where they underwent an elective post-operative case and from a hospital, usually is a resistant flora. And there is a complex multi-drug regimens to be included, and adequate empiric therapy, if not started on time, will have a very high mortality. So what are the organisms we are going to deal in such case of patients? First thing is ESBL producing Klebsiella and E. coli, non-fermenting gram-negative Pseudomonas, Acinetobacter, Proteus, MRSA, and Enterococci. Enterococci very common in patients like this who have severe abdominal infection, post-op case. He had all the features of this, and Candida species. Then these are some of the most common organisms. So what are we worried in this case? Whether we are dealing with an ESBL or whether we are dealing with a carbapenem resistant Enterobacteriaceae, or in a rare event, are we really dealing with a case like a colistin resistant Enterobacteriaceae? So how do we get to this conclusion? The main is the risk factors we have to see and by the history. So the risk factors for developing an ESBL is hospitalization in the last 48 hours within the last 90 days, broad spectrum antibiotics for 5 days within the last 90 days. Both of this our patient had. And colonization by ESBL within the 90 days is also there, but we don't have the previous blood reports. So if you are dealing with a carbapenem resistance Enterobacteriaceae, these are the genes we are supposed to see, APC, MBLs, and OXA48. I don't think many of the labs in the Indian laboratory give this genetic testing values. So how do we deal with it, or how do we know we are dealing with the CRE? Again, we have to go by the literature and we have to ask the history. These are the risk factors for the patient to develop a CRE. We are all supposed to do a screening for these kind of patients. And the main factors which you see here, our patient had fit into all of these criteria. Main patient, age in years, patient received from other healthcare facility, high antibiotic exposure, history of surgery, endotracheal intubation, central line, Foley's, and systemic infection. So what are the therapies we have for these kind of cases which are CRE? So it is a high-dose tetracycline, high-dose prolonged infusion of a carbapenem, double carbapenem therapy, ceftazidime, avibactam, meropenem, plazomicin, ervacycline, and imipenem, cilastatin, relebactam, or cefetroxol. So as per the IDSA guidelines, when you are suspecting an MDR tattoo in the abdomen, you are supposed to start tetracycline or ervacycline plus meropenem, imipenem, or doripenem plus vancomycin. Vancomycin, whenever you are giving, you are supposed to monitor the trough levels. As most of these guidelines come from the abroad countries where they monitor the trough levels, they usually recommend vancomycin, but I personally prefer using teicoplanin as it is safe also in giving in renal failure patients. And antifungal need to be added. If the patient is stable, fluconazole is a good choice. If it is unstable, then it has to be echinocandin. If there are proven MDR cultures that is there, then you can directly go and use the ceftazidime tazobactam or a Pseudomonas positive ceftazidime avibactam. Our patient didn't have a risk for VRI, and if risk for VRI is there, then you have to start with linezolid. So this is a good study where they compared the efficacy of the teicoplanin versus vancomycin, and they finally concluded that teicoplanin is not at all inferior to vancomycin, especially with regard to efficacy, and is associated with a lower adverse event rate than mitomycin. So what did we give finally? High-dose meropenem as infusion targeting the bacteremia. In spite of knowing that maybe it is a case of CRE and it is previously treated with meropenem, we did start high-dose meropenem because the evidence says even high-dose meropenem is favorable in CRE and it should be always used in combination with colistin and poly-B. So poly-B also we had added, which is good for bacteremia and tissue penetration. And this combination of high-dose meropenem and poly-B acts as a synergistic effect. Tetracycline we had started because one thing we should always remember when we give tetracycline is it does not achieve a therapeutic concentrations in blood. So it is not ineffective in bacteremia, but it has an excellent tissue penetration and it has no action on Klebsiella and Pseudomonas. Teicoplanin also we gave thinking that it might be an Enterococcus or MRSA. Flucon also we gave because at that time we didn't have availability of caspofungin. So these are some of the trials which compared this high-dose meropenem where they told that SOFA score greater than 7 and Apache greater than 20, especially if the patient is getting admitted from the emergency department, it shows a superior microbiological cure. A combination of polymyxin with other drugs also is very good for even resistant organism including the superbugs. So finally, here are the guidelines for the gastrointestinal biliary tract if you are suspecting an MDR bug. So the empiric treatment, high-dose meropenem or doripenem, polymyxin B and high-dose tetracycline. So what did we observe after doing? In the second day, the total count reduced to 15,000. BP was relatively stable at around 60 to 80 systolic with some improvement in ABG and consciousness, and we continued with CRRT. So what are the advantages of CRRT? CRRT in hemodynamically unstable, it is very good. It maintains hemodynamical stability, management of fluid overload, control of urea, creatinine, nutritional support, precise volume control, improved nutritional support, rapid control of acidosis. Apart from all these advantages, the one more is the removal of the inflammatory cytokines. It removes all the cytokines that are coming in between the size of 30 to 40 kilodaltons. It regulates inflammation. Most of your interleukins, especially the interleukin 6 and the MIF will be removed. And the TNF alpha is not removed in this because it is 51 kilodaltons. And reduced MIF decreases renal injury, and the heparin uses reduces inflammation, and the extra energy supply to kidneys improve energy balance. So this is the ABG we saw, which we have taken in the first 24 hours, the serial ABGs. Finally, after the 24 hours, we saw there is an improvement in the pH along with the bicarbonate and PaO. And the cultures which we have taken initially, what did it show? The fluid from the wound showed Enterobacter faecium, and the gram stain was showing cocaine bears, and blood was showing Staphylococcus hemolyticus. So we stopped the polymyxin once the hemodynamics became relatively stable. We continued with meropenem, tetracycline, teicoplanin, flucon. So this is the culture report. In the next few days, the patient was off anaerobes, off ventilator, off dialysis, good output, off sheet and negative balance, and tracheostomized early, and he was mobilized. So there was a plan for surgical intervention for the source control as per the discretion of surgeons, and the intra-op findings, there was a burst abdomen, anastomotic dehiscence of the AEJ, and the wash and repair was done. Post-op again, he was shifted to SICU where we decided to give a short course of meropenem, sulbactam, linezolid, and flucon. And the cultures were sent in the OT, showed a moderate growth for Candida albicans. Since he was already on fluconazole and he was doing well, we didn't bother much about this. So we continued. In the post-operative period, the first 2 days he was doing fine, he was off ventilator. From the day 3, all of a sudden we started observing the platelet count has come down significantly, like 1.27, and the creatinine increased again. There is a need for oxygen all of a sudden, and the USG showed us some consolidation. Total counts have increased, platelets have again fallen down, and the creat has increased. On the day 5, we did an X-ray, it was showing the right lower lobe haziness. We suspected MDR VAP as he was already on many antibiotics, so we straight away started on polymyxin B. And in view of this increased creatinine in meropenem, sulbactam, we reduced the dose, we stopped the sulbactam, and we gave a very small dose of meropenem because poly B as such is more of a static and less of a lytic. So we had to combine with meropenem, otherwise in a period of another 5 days he will develop resistance for this. So on the day 6, and that is on the next day of starting this antibiotic, he was completely fine, he was off oxygen, and the creat and the counts and all started settling. By day 7, it was almost normal. So the cultures which we have taken for the second time during this episode, we had a surprise that growth that in the trachea it was Burkholderia and in the blood it was Candidemia and again in the blood it was Burkholderia. So as soon as we saw this Candidemia, we removed the invasive central line and we started on the caspofungin. So fungal Candidemia started on caspofungin, removed in the next 48 hours patient general condition improved and was shifted to ward. So why did we decide to shift to again an echinocandin? So the general consensus in an ICU patient is if you are really sick, start the patient on echinocandin or liposomal amphotericin. If you are already on azole and develop an infection, start echinocandin. If you have an aspergillus, go for voriconazole. If you are stable with likely albicans, go for fluconazole. If your candida is online, echinocandin is again the choice. So here it has developed from the central line. So anyways, whenever a patient on central line develops a candidemia, there are more chances of having a biofilm. So in presence of biofilm, the regular azoles will not work and the regular amphotericin also will not work. So the choice will be either going for an alidolafungin, micafungin or go for a caspofungin. So in candidemia, we have to remove all the vascular devices, even if it is other devices also, the biofilm chances are more, so we have to remove. And albicans and the paraceliosis of the Candida species are more notorious to cause biofilm. So this is the articles which support the statement which I have made that biofilms and beyond, where the echinocandins has more utility. So azoles and conventional amphotericin doesn't work. Biofilms are there. It is resistant against antifungals. So all the echinocandins only can work. So what about the other species which I encountered, which is a Burkholderia capacicea? It is basically a gram-negative, very resistant bacteria, and it is an opportunistic pathogen. It is a spear, contemporary of like Pseudomonas bacteria. So where did we get this opportunistic infection? Maybe we had given him a lot of antibiotics, the gut biome axis is damaged, and he was on mechanical ventilator, catheters, immunocompromised probably, or a pharmaceutical contamination or a water contamination. So we all had a doubt that whether should we really treat this organism or no, since the patient was not having any fever or any pneumonia and everything got settled because of polymyxin and after adding the antifungal. So usually this Burkholderia cephacea causes a cephacea syndrome, most commonly in patients with cystic fibrosis or a chronic granulomatous disease. Since our patient was not onto this, so we didn't bother much. And seeing the treatment regimen, it is usually sensitive to the meropenem and trimethoprim sulfacetal and ceftazidime. So we called the microbiologist, but the sir was of the opinion that it is a resistant bug. So we have to again escalate the antibiotic to ceftazidime. But then based on the UCAST of the CLSI guidelines, meropenem susceptibility MIC values approximately equal to 16 also you can treat with the same. So we decided to treat the patient again, continue with the meropenem. And the day before the discharge of the patient, again we have repeated the culture. It didn't show bacteremia, it didn't show candidemia, but again the one more central line which I put has again had a Burkholderia species. So again, we did a polymyxin and caspofungin and meropenem. We have de-escalated based on the procal values, and we discharged the patient with the advice of Bactrim DS, and fluconazole we continued for 2 weeks again. So summary, complicated intra-abdominal infections are difficult to treat. Early detection and antibiotic source control is the key. Fever in post-op needs evaluation. Good knowledge of IV antibiotics, site of action, effective antibiotics for that site is important. Surviving sepsis guidelines, fluid resuscitation is the most important. Bedside USG is very helpful. It gives an repeatability, it saves a lot of cost, and it is very fast, and it avoids shifting of the patient. CRRT when available and the patient is affordable, it is always good. PKPD of the drugs is the most important. Infection control and hand hygiene is important. Antibiotic stewardship. One more thing is the infection control committee. They should be headed by a microbiologist. Whenever there is a super resistant bug or whenever there is a prescription of ceftazidime avibactam, it should usually come from this infection control committee, headed by a senior physician or a microbiologist or an intensivist. And whenever such drugs are being prescribed more than 5 days, it has to be checked again for timely de-escalation. So there is a lot of confusion in treating such cases, especially when they are stable, when they are immunosuppressed, when they stay for a long time, whether really to treat the patient or to treat the report. In this case, we went with the patient. So good supportive care and nutrition works best. So finally, I would like to say all the clinicians, whoever is there, to go for an antibiotic cycling, use this side of the drugs more, leave this only as a reserve and use it for the sick patients. So if you don't do this, then GNB-MBR sepsis is the future pandemic and let's have an antibiotic reserve. So what went great in handling this patient? All of you might agree this, humble and well-mannered family members. And
I think we should congratulate the entire team of intensive patient out of ICU. We never thought that he could make till the time till this. Of this patient for almost 30 days without a single blood store. Thank you very much, sir.
Any questions from the audience, sir?
Yeah, intraoperatively when we opened, the entire abdomen was full of pus with a lot of adhesions, interloop pus. But we couldn't find that adhesion somehow. When we opened, we found that only posterior layer of esophageal was intact. The entire anterior layer was open. So from that it was leaking. So we were really wondering at the time of that, I really washed out actually to think that what to do next because there was no esophageal stump and the patient was not fit for the thoracotomy next. So somehow I mobilized, we were mobilized the crus of the diaphragm and got some few centimeters of esophageal stump and then we switched hoping for the best. We never hoped that it would heal actually, but our body is so wonderful that the moment we bring two ends together, it will strike hitch together actually. So that's what happened. Luckily over the next 5 days it didn't leak and we went home.
Thank you, Dr. Arjun, for this wonderful case. Please.
Putting notes, everything. He requested me to see the patient, sir, anything I have missed, please let me know. I just went through pages of his notes, counseling the family members. At last I just closed the patient and told the sister, I don't want to become an idiot in front of everybody. I don't want to write anything. That's also a serious note that I think updating is beyond at least my age. Pharmacology, microbiology, intensive care, nephrologist. In fact, Shivraj came from Davangere to do a endoscopy to see where is the leak and whether it is possible to put a stent. That is the kind of things happen with this patient. As I Arjun told, it's purely because of patient's party. I think one should be very lucky to get such patients. They were crying for 3 days and all the next 4, till they discharged, they were smiling and not even one bad word or question asked to any of the doctors. Thanks to the team and the family members. Now we come to fourth talk, which is from the duo of oncosurgeons. Though it is mentioned Dr. Guruchana, I am very sure Dr. Aravindan also will join this presentation and Dr. Rakesh will remain there to chair this session. Dr. Guru and Dr. Aravindan, please.
Organizers and entire team for being here this wonderful evening. As we all know that cancer incidence is increasing year by year. It's no more a disease of Western countries or developed countries. Previously we used to wonder why this cancer is so much high innovation countries. Now it is really in front of us. All over the world, the incidence is increased to 90 million new cases per year worldwide. Out of that, you might be wondering, India is contributing to around 5 to 6 million cases per year. New incidences. These are the new cases. I think in other, by WHO estimations, by 2030-35, India is going to become cancer capital of the world. So that's what's happening, probably because of our own lifestyle diseases and especially thanks to our reconnect and tobacco. Coming to this one, the international guidelines, NCCN, either European guidelines or by WHO, says that patient guidelines. It says that better to get treated under a comprehensive cancer care team. It never mentioned that go to a single center, single person, like not like that. It is a comprehensive cancer team. I think we at Nanjappa hospitals are very thankful for the management for establishing this totally comprehensive cancer team comprising of almost all departments. And till now, we have done around more than 1,000 cases of major and supra-major cases in the last 2.5 years, including cytoreduction hyper cases. And luckily, in last week, we could do totally 4 cases of for esophageal cancers and lung cancers. So we are very proud of that. And we at the center have done almost more than 1,200 PET scans and more than 3,500 chemotherapies and more than 500 cases of radiation therapy till now. And also we have done almost more than 4,200 cases of major oncopathology along with IHCs. So we are really proud of this and we would like to thank our management for this providing facilities for this entire central Karnataka. So with this, I would like to, we would like to share 1 or 2 cases which we have done recently, and Dr. Arvind, my friend and their colleague, will be explaining these 2 cases. Over to Dr. Arvind. Thank you.
Thank you, sir. Good evening, everyone. From the brainstorming session of medical topics for the next 2 minutes, I'll try to finish in 8 minutes regarding our surgical topics. So coming to first case, this is a 49-year-old lady who is with well-paid, well-nourished, who had got evaluated by ultrasound abdomen in somewhere else in some other district. Was just given the report as gallstones. There was nothing else. So she underwent laparoscopic cholecystectomy. It was told it was chronic cholecystitis. But after 1 month, around after 1 month, she went back to the same surgeon. Then he got scared and they got a CCT done. He showed large momental deposits and some ascites. So the momental deposits, such a large deposits, were not there just 1 month before. Where did they come from? We don't know. Next. So these are some of the doubts which comes to my mind. Where were these nodules already there during the previous lab? So they seen just missed something concealed like that. Is the biopsy report is because carcinoma gallbladder is so bad disease and it will progress so fast. I first immediately thought that it might be probably metastatic carcinoma gallbladder and it has spilled out. That whatever the contents are spilled out and immediately within 1 month it has grown so badly. So is it some aggressive malignancy drastically increased in 1 month? But unfortunately we could not get the slides and blocks because of whatever logistic reasons. So that lady had got 1 cycle of chemotherapy outside, then she was referred to our center where we got ultrasound guided biopsies from the mental deposits. and IHC was proven that it's a case of peritoneal mesothelioma. So immediately discussion was done, and we got a PET scan done. Click on that. Yeah. The PET scan showed extensive disease, extensive surface lesion along with the scalloping of the liver and the multiple deposits of the peritoneal surface and big momental deposits, then the deposits along the colon, then POD deposits. PET scan, actually PET scan was done only to see any other, primary is there somewhere else or. So then, coming to peritoneal mesothelioma, it's quite rare but a lethal cancer. The most commonly, it's related to the asbestos exposure, but I don't know how much it is for the Indian people. It's related. Then most of the patients come with pain abdomen and distension of the abdomen or some vague symptoms. CT scan, CECT is done mainly to assess whether we are missing any primary somewhere else or the extent of disease, whether resectability, all those things. In patients with good performance score and the disease amenable for surgery, complete resection of the tumor along with IPEC is the treatment of choice as of now. And still, with that also, since it's an aggressive tumor, the overall survival ranges something from 38 to 50 months. So these are some of the studies. Most of the studies shows the 53-month survival with CRS IPEC is something around 38 to 59%. Coming to cytoreductive surgery as such, this is surgery done to diminish the total tumor burden. So how much ever it is, how much ever it will be, to some or whatever extent you can remove, that will be better. So at present it is complete tumor removal of CC0 is recommended, but even if we can cytoreduce, that will also be okay. So this is especially true for the tumors which responds well to the chemo, so that the minimal amount of tumor or the microscopic disease, if it remains also, that can be treated by chemotherapy. So removal of large masses, CC0, if we do the 80 to 90%, 99% of the tumor burden will be removed. So he is also called as the father of CRS. So our cytoreductive surgery, he initially almost 20 years back, he had given the recommendations like at least 0.5 centimeter of residual tumor if we give also, that can be acted upon by chemotherapy. But at present, the recommendation is there should be no gross visible disease on any surface. So on opening the abdomen or assessing, even with CT scan also we will do same thing. Otherwise, on opening the abdomen we will do some qualitative analysis, but as a PCI or peritoneal cancer index. So depending upon how much big, how many deposits are there in each quadrant of the abdomen and all over the bowel. So total count, the PCI score depends what's the prognosis of the disease. And in some, this prognosis also depends on which type of, the pathology of the disease also. Then in some diseases like gastric cancer and all, if it is more than 12, it's better not to operate. In peritoneal mesothelioma or primary peritoneal carcinoma or CRC and in ovarian malignancies, even though the PCI score is more, we can go ahead with surgery. So as much as the anesthetist is also very important, post-operative care and intraoperative care. So we have to keep the patient warm because such a large area of the abdomen will be exposed. To maintain the temperature, initially we have to keep them warm, and then during the high PEC we have to cool the patients. So urine output should be monitored. Urine output should be monitored, PTINR. Urine output should be monitored, PTINR, and post-operative electrolyte management and perioperative pain management will be more important. Fortunately, we have anesthetist who will tell for everything, whatever it is, he will manage. Okay, then these are some of the steps of peritonectomy, which shows anterior peritonectomy and the subdiaphragmatic and Gleason's capsulectomy. This is the next one is a video with in that mesothelioma patient. So there's a large incision from the epigastrium to the pubic symphysis. Then we entered with the anterior peritonectomy. The peritoneum just below the posterior layer of the rectus. Just once tap it. Okay. Okay. So this is the posterior, just behind the posterior layer of the rectus. We went and slowly dissected with the blunt resection or the sharp dissection. This is a video showing the peritoneal resection in the right subdiaphragmatic space. Then this is in the left subdiaphragmatic space. The one thing we are holding is the spleen, and this one is a video showing the pelvic peritoneal dissection. The peritoneum was dissected slowly from the bladder. First we fill the bladder with methylene blue, and then this is omentectomy. So omentum was full of, it was not looking like omentum actually. So it was full of polyps. And then at the end we will look for any deposits over the bowel and also check for any bowel injuries. Next. So this is one more lady which we did after 4 days of the first surgery. We did CRS effect for one young lady with carcinoma stomach. It's a case of minimal disease but metastatic carcinoma stomach. Initially we had done diagnostic lab and detected it as metastatic disease, but with flawed chemotherapy she had very good response and there was no disease elsewhere. So we went ahead with CRS, removed total gastrectomy and omentectomy and PHBSO along with total removal of all the peritoneum. So high PEC, it's like it's combined. Only CRS, if high PEC is along with CRS, the survival rate or prognosis is much better. In high PEC, we give up to 3 to 6 liters of warm saline or peritoneal dialysis fluid or about 41 to 43 degree temperature. Depending upon the patient condition. What we practice is 42 degrees for 90 minutes. We use close method, that is finish all the resection, anastomosis, and then close the abdomen with one sheet, and then we will give the this. We usually rent the machine. This is called Novapec machine. Then next one. So this is what is a colosseum method or close method. This looks like the colosseum method. And this is our high-tech machine which we get it for rent. So this is a peritoneal dialysis fluid. These are the tubings. Two inlets, one is in the right subdiaphragmatic space and one is in the left subdiaphragmatic space. And two outlets will be there in the pelvis. The temperature will be monitored. What are the temperatures in the input and what are the temperatures in the output. So that will be showing the output temperature should be maintained something around 41 degree plus. Okay, coming to the second case. This is also, central lymph node biopsy is also, in human biologists, we are the only one who are doing central lymph nodes. As we all know, central lymph node is the first draining lymph node of any organ, of that representative organ. So if central lymph node is positive, then we don't need to do complete lymph node dissection of the axilla. Complete lymph node dissection is not free. Okay, if it is positive, then we will go ahead and do. Next. So what we practice is, because of logistic reasons, we do single dye method. That's only methylene blue we use. Other types are technetium 99 or ICG. The injection initially we used to give peritumoral deep injection of around 2 ml. Now we are practicing flare method. Only 0.2 cc of methylene blue will give. And then pathological assessment also by touch preparation will do. Most of the most common malignancies what we are doing is SLMP is for breast. And other rare disease will be malignant melanoma, CFNS or vulval malignancies. And in some cases, CA endometrium or CA cervix, once we had ICG camera, we were doing ICG based central lymph node. Okay? So this is just to say that if only one lymph node is involved or not at all involved also, why to punish the whole axilla for that? So this is not fair. When we were small, it's not fair ಅಂತ ಅನ್ಸುತ್ತೆ. So next, similarly, the apple, I don't know, maybe like if it is 10 rupees 1 kg, we might have thrown all the basket, but it's quite costly. So like that, removing full axilla is quite costly for the patient, like in terms of post-operative complications or long-term risks. Next. This is the same method. 0.2 ml of sterilized methylene blue is given intradermally at the area where we are going to remove later. Next video. So 0.2 ml is injected. This is a case of mastectomy, so we have a large area to inject wherever we want. And then little bit of cupping we will do. Then either in VCT we will do a small just below the lower airline incision, which you can see the methylene blue, the lymphatic tracking through the axilla, and then the single node is just taken, that methylene blue will be taken. Will be dissect only at least 3 to 4 nodes and we will send for histopathological assessment. Then within 20 minutes, our oncopathologist Dr. Venkatesh sir will give the report. In that, what we will do is, we will first click on that. Okay, you will measure the lymph node what we have sent, grossly whether it is positive or not, you will check. Along the short axis, you will take, you will make it into 3 pieces. Then with the glass slide, you will take the, scrape out the contents. Then make a slide on the microscope.
Thank you, Dr. Venkatesh.
Next. So other malignancies are like use of, ICG. If we have an ICG based camera, we can use it for almost anything. Like in axilla also, we can use the ICG, or in service, or say endometrium. Other cases we can use the ICG, or even the ICG we can make use for determine the level of resection in colon cases, etc. At the end, this is the last slide. So at the end of this thing, I'm going to stop this talk with our usual slogan. Hopefully, it is a lack of knowledge. Thank you all.
Okay, sir. Any other questions from the audience?
Sure of the diagnosis. I think our oncopathologists did extensive IHC study to come to the diagnosis of mesothelioma. So I think we are lucky for that. And this surgery started at morning at 8 a.m. and we finished at night 10:30. So I think to withstand so much of time surgery and to almost more than 12 hours of surgery, anesthesiologist's role is very, very important intraoperatively. We are in that actually we are lucky to have this excellent team of anesthesiologists and intensivists in our Nanjappa life here to do these kind of supra-major surgeries.
I think we have finished half innings.
I request Dr. Srikanth Nandine to come out the dais and be a panelist for the next 2 cases. I request Dr. Vishwanath Nichan, our pediatrician at Nanjappa Hospital, for his next presentation on pediatric acute liver failure. Dr. Vishwanath, please.
Last 3 to 4 years in our department. To begin with, we all know clinical course of pediatric acute liver failure is rapid, dynamic and unpredictable. Because the interval between the presentation and clinical outcome can be as short as few hours or days. Every child may require liver transplantation. The cases, since they were not willing, they were managed here itself. So the definition of liver transplantation is very important. It's acute onset of liver disease without any evidence of chronic liver disease, biochemical evidence of severe liver injury, and coagulopathy not corrected by vitamin K, like INR of more than 1.5 with evidence of hepatic encephalopathy, and INR of more than 2 with or without encephalopathy. This is a landmark study done between 1999 to 2014 in 19 pediatric liver transplant centers across USA, Canada, and UK, involving 1,144 children with the following entry criteria. So, it is extremely difficult to predict which patients would spontaneously recover with their native liver with supportive care and which would go on to have fatal consequences if not transplanted. As the figure shows, few cases, this hallmark tells liver transplantation, few cases required liver transplantation in their initial course itself, few required at the middle course, few later. Hence, it's very unpredictable and they should be referred as early as possible. So, this is case 1, H1 15-year-old male child, presented with, is a known case of seizure disorder on Levipil. He presented to us with history of vomiting, malaise, headache for 1 week. He was hemodynamically stable, conscious and oriented. Examination was grossly normal apart from severe epigastric tenderness. USG abdomen done outside was normal. His investigations were grossly normal apart from leukopenia and grossly elevated liver enzymes, elevated bilirubin, and his INR was 7.6. And his other etiological investigations like lepto, hepatitis A, hepatitis C, and dengue, everything was negative. His cultures were sterile, and so he was admitted in PICU. He didn't have any features of bleeding or features of hepatic encephalopathy. So he was treated with supportive measures like vitamin K, NAC infusions, N-acetylcysteine infusions, broad spectrum antibiotics, lactulose, and PPI infusions. He was in hospital for 5 days. His repeat investigation showing improving trend. His INR improved to normal on day 4. On follow-up after 2 weeks, he was stable and his investigations were within normal limits. This is the second case, Meghraj, male, 1 year 6 months, presented with acute GE, features of acute GE. At admission, he was sick looking, hypoxic, and was in compensated shock. He received fluid boluses, oxygen through NRM, and antibiotic within 1 hour of hospital admission in ER after sending cultures, and shifted to PICU. His initial gas was showing some metabolic acidosis with elevated lactate. So after 12 hours, he had worsening of his general status in the form of abdominal distension. He required non-invasive ventilation, colloids, inotropes, and ascitic tapping in view of abdominal compartment syndrome. With the above measures, he was symptomatically better, and his APG was showing some improving trend in the lactate. It was initially 4, it decreased to 2.2. That was the first good sign for us. So his investigations were showing thrombocytopenia, elevated liver enzymes. So bilirubin was elevated. His INR was 2.606 at admission. Within 12 hours, it jumped to 10.6. His APTT was 300. Albumin was low. His procal was positive. Urea was elevated. His NU test was positive. In this case, there is multiple band marks for the body. They used to do in the villages. So, and his investigation showing features of DIC, dengue, septic shock, and features of MOTS. He was admitted in PICU, treated with broad spectrum antibiotics, albumin, and inotropes, treated with blood products since he had an episode of GI bleed in the form of melena with a drop in HB. So he received anti-liver failure measures, and he had soft tissue infection in lower limbs. So hence he covered for MRSA also. No features of hepatic encephalopathy throughout his admission. In throat, he was conscious and oriented. He was discharged after 2 weeks of hospital stay. On follow-up, he was stable. This is the third case. Amrita, 14-year-old girl, with history of RTA, treated in a local hospital for 3 to 4 days before coming to our hospital. As per mother, she was drowsy 2 days before coming here. On arrival, she was in decompensated shock, heart rate were 160, BP was 80 over 50, saturations were normal. In room air, her GCS was low. So her abdomen was soft. She was electively intubated with anti-ACP measures, treated with antibiotics, started on inotropes in ER and shifted to ICU. Our investigation showing again leukopenia, grossly elevated OTPT, and bilirubin was 5.9, INR was elevated grossly, and our renal functions were abnormal, and ammonia was grossly elevated, 300. She was in severe liver failure with grade 3 to grade 4 hepatic encephalopathy. She was treated with all anti-liver failure measures, but continued on mechanical ventilation. Nephro opinion was taken. She received broad spectrum antibiotics and antifungals. In this case, she was persistently having severe neutropenia. So, in view of that, we tried filgrastim also. So, to increase the neutrophil count. Initial 48 hours, her urine output was adequate, creatinine was decreasing, but she was comatose throughout her hospital stay. Even after our supportive measures, she became again hypotensive, anuric, and succumbed. So totally we managed 3 cases. In first case, he presented only with only with the elevated INR with no features of bleeding and hepatic encephalopathy, was hemodynamically stable at admission. So he responded to our usual supportive measures, and here we didn't get any etiology. In second case, he presented bit late with the features of compensated shock. He was having in his hospital stay, he was having some bleeding manifestations, and he was having features of abdominal compartment syndrome and elevated INR. He required some blood products and pretty prolonged hospital stay. Here the cause could be dengue fever with septic shock. The third case, she presented to us with very late in grade 3 to grade 4 hepatic encephalopathy. She didn't have any bleeding manifestations, but she was having all multiple organ dysfunction, and INR was 10.6. Even INR didn't come down even with our therapies. So we supported her with all supportive measures, but still she didn't make. So coming to etiology, this is from the same study, pediatric acute liver failure study group, which shows almost 43% of the cases we don't know the cause, indeterminate. And another 13% is paracetamol. So out of these two will make almost 55% of the total etiology. So it's important to know something about indeterminate pediatric acute liver failure, which involves up to 40% of cases. The cause could be aberrant immune system activation. There is unique hepatic inflammation pattern in this indeterminate pediatric acute liver failure, where liver biopsy may help for diagnosing it, and these are the candidates can go for liver transplantation. And immunosuppression may be a modality. We need few more studies to start some therapy against these diseases. So a few more slides, another 3 to 4 slides. This is coagulopathy in pediatric acute liver failure. So acute liver failure is a rebalanced hemostasis situation, which sometimes favors thrombosis. Risk of spontaneous bleeding in acute liver failure is less than 5%. Risk of spontaneous intracranial bleeding is less than 1%. Bleeding risk is less compared to chronic liver disease because of absence of portal hypertension and esophageal varices. So INR is the risk does not correlate with INR values. Risk of bleeding does not correlate with INR values. So this is the rebalanced hemostasis, where in liver failure both procoagulant and anticoagulant factors will be decreased. This rebalance occurs at primary hemostasis, secondary hemostasis, and fibrinolysis levels. So this we should all know. So some lines about PTINR. Elevated PTINR obviously marks the severe hepatocellular dysfunction, but PT-INR measures only procoagulant factors, do not provide information on actual fibrin formation or clot lysis. Hence, we need to replace this test with some other more informative test like viscoelastic hemostatic assays such as thromboelastography and rotational thromboelastography, which will give us full picture of clotting and this procoagulant and anticoagulant factors. So most of the scores which involve INR as a marker, so it is more of prognostic marker and it's not a investigation which will tell us the risk of bleeding. So if you start treating elevated INR with blood products, we need to be ready with accepting the complications. Like it increases the mortality, it may increase the need for liver transplantation, there is a risk of transfusion related acute lung injury, cardiac overload and immunomodulation and risk of cerebral edema. So after, if we transfuse with FFP elevated INR, it loses its prognostic value. So cause of cerebral edema is, this is from World Journal Gastroenterology, which tells, so life-threatening ICP is rare. So mechanism of cerebral edema in acute liver failure is cytotoxic edema with astrocyte swelling. So definitely there is a role of ammonia. So ammonia, there is glutamine accumulation in astrocytes. Glutamine acts as a carrier for ammonia to mitochondria in astrocytes. So it will accumulate and cause cytotoxic edema. So liver transplantation is the liver transplantation is the mode of treatment in this situation. So there is this is from Hispanic guidelines. Depending on the values, if we do any acute liver failure, if we do ammonia levels through arterial blood, so if the values are less than 75, there is risk likely to develop rise ICP. If the values are more 100, they are more prone to develop high-grade hepatic encephalopathy. If the values are more than 200, strongly associated with cerebral herniation. So there is a role of plasmapheresis in pediatric, in adults, in adult liver failures, but in children still more studies are required. It improves the coagulation profile, but there is no sustained improvement in neurological function. In this study, only 49 children underwent plasmapheresis. Out of that, spontaneous recovered only 3 patients. 32 underwent liver transplantation. So these are the scores we use. Still, there is nothing like perfect score. Still, these are the liver LIU score, PELD and PELD scores may be used in acute liver failure situation, but there is nothing called perfect score. Thank you.
Thank you, Dr. Vishwanath, for the interesting cases. If there are any questions, the topic is open for discussion.
In the third patient,
Yes, ma'am.
what CT abdominal? Because RTA you said.
Yes, ma'am. The USG, she was having outside.
And in the third case, since the patient had RTM, he was on inotropes, mechanical ventilation and all, it can be a shock liver, simple shock liver where everything can be negative and only elevated liver enzymes and liver failure can be a presentation.
Yes, sir. This, only thing is, I wanted to explain about that indeterminate part. So that's why. Else, we didn't get correct cause. Like second case, we got dengue and septic shock. There is nothing like straightforward in that in those 2 cases. So just to explain properly, so we could have investigated further. The viral panels we didn't have, sir. Cytomegalovirus and RPs, those blood tests we didn't have. So if we do, we could have got. I don't know.
The key message to echo message is to
don't rely only on bilirubin or enzymes. Look for other markers like INR, PTINR, which can change very drastically, especially in case.
And we need to give an option to all attenders. So if you are dealing with any liver transplant, acute liver failure, since the course is very unpredictable, so we don't know the cause, we don't know the course. So it's better to manage in a liver transplant center. So because within days they may deteriorate.
Thank you, Dr. Vishnu, for your excellent presentation. To catch up with time, we have our next case being presented from Dr. Spurti Pai, our endocrinologist at Nanjappa Hospital, Shivamogga. I request Dr. Spurti Pai to come up and ask.
Thank you very much for introducing me. So I have a single case to present today. Since we have only few minutes for each presentation, so I will be not going into the theory part of it. It's only purely clinical case. And I have named it as a different case of diabetes with a star. So diabetes mellitus we see day to day. Let's see what it is. So she was a 60-year-old female. She's a known case of diabetes mellitus since 4 years. Left CA buccal mucosa, admitted for surgery. She had received recent chemotherapy cycles prior to surgery with carboplatin and paclitaxel. Pre-op workup did not show any significant abnormality except for elevated HbA1c, which was 9, for which the patient had been already initiated on insulin by our physician. And she underwent left hemiglosectomy with, I think I missed it, so it was left hemimandibulectomy for the field. In the post-operative period, patient developed sudden increase in the urine output, which was around 250-300 ml per hour, and she was admitted to SICU. Pre-operative sodium, when noticed, it was 144.9, which was slightly on the higher side of the normal. Post-op day 1, it suddenly became 173.9. So she was started on free water correction with 5% dextrose along with insulin infusion to control her sugars, and free water through RT over the next 48 hours, and she was managed via intensivist team, which was very well managed. But she persisted to have a higher sodium. Sodium, we don't correct it suddenly. We cannot bring down to normal levels in one day. We have a limit that it can cause cerebral edema if we correct it drastically. So the repeat sodium on post-op day 2 was 164, then it became 159 on post-op day 3. Again, it's persisted to be high despite free water correction, and output did not reduce. So initial post-operative period, there are many causes which can lead to diuresis. Post-operative diuresis because of the intra-op and pre-op fluids is the most common thing. But it is very rare to get a scenario where you have a sodium of 173 suddenly post-operatively after surgery. So there was something else which was going on. Glycemia was well controlled, the sugars were all below 200 with insulin infusion, but still there was diuresis which was going on, so it was not osmotic diuresis. It was something else. Hypokalemia was also there, which was corrected. The history was re-evaluated, did not suggest any polyuria polydipsia prior to surgery, whether we missed any pre-operative DI, because pre-op sodium was on the higher side of the normal, but that was not suggestive. No history suggestive any headache, visual blurring, any other pituitary tumoral hormonal excess was ruled out by history. So other investigations were sent, only bare minimum investigations were sent because the patient was unaffordable. We didn't do the whole panel of it. Whatever was necessary was done. Cortisol was on the higher side, so cortisol deficiency was ruled out. Thyroid hormones were normal, free T4 was normal. Sodium again on the post-op day 3 was 159. At that time, a serum osmolality was done, which was very high. Urine sodium was 59, urine osmolality was 343. This urine osmolality is a calculated osmolality which we do. We don't have a direct urine osmolality measurement in our lab as of now. With the sodium of 159, urine osmolality in DI, clear-cut DI, it should be less than 100, but here it was slightly on the higher side. But clinically still the output was more than 250, so we thought it could be still a case of DI. Got an MRI cellular done with contrast also was done to rule out any other metastasis because it was a case of malignancy. Posterior pituitary mets are more common than anterior pituitary metastasis because posterior pituitary gets direct blood supply, whereas anterior pituitary has a portal venous circulation. The mets are uncommon, the mets get trapped, and posterior pituitary is more common to have mets. But we did not find any mass in the posterior pituitary. However, posterior pituitary bright spot was not there, meaning that the arginine vasopressin which is being produced and stored in the granules in the posterior pituitary is not there, it is deficient. So posterior pituitary bright spot absent, anterior pituitary no abnormality. The other common cause is hypophysitis, where you can get a diabetes insipidus. So this is a case of diabetes insipidus. Posterior pituitary mets or hypophysitis is a DD for getting central DI. So hypophysitis also was ruled out. The stalk becomes thickened when you have hypophysitis, and cortisol is usually low. Both the things were not there in our patient, so we ruled out a hypophysitis. No other infarcts, no stalk thickening noted. So clinically we diagnosed it as central DI. Cause was still not known. Whether we could think it as clinically central DI because response of urine output to vasopressin was seen. So we gave a subcutaneous dose of vasopressin and the outputs drastically came down. 250 became suddenly 75-50. So it was a clear-cut response to vasopressin, which is not seen in nephrogenic DI, it is seen in only central DI. So still the clinical diagnosis, despite the urine osmolality not being less than 100, is central DI. And posterior pituitary again suggests that central DI is a possibility. However, we also have to note that 10% of the normal population also may not have a posterior pituitary bright spot, but clinical history suggests of central DI, this diagnosed as central DI. Type 2 diabetes was controlled and the final diagnosis was this. So what was the cause of this DI in our patient? There was no other pituitary lesion which was found. Is it common to get a DI without any other cause? So one thing I wondered was whether it was a masked DI. Preoperatively the patient already had DI, but we diagnosed it later on. As the patient had undergone hemimandibulectomy, she was unable to speak and she was not able to give the history by herself. She was not able to indicate the thirst. Because thirst is an important factor. They keep drinking water even if they have DI, it gets masked. But when you have such kind of stress and surgery where you can't ask for water, that is the state when suddenly they become hypernatremia. They get hypernatremia. So that was one thing which I thought would be most likely. Chemotherapeutic agents can commonly cause nephrogenic DI. Carboplatin also can induce nephrogenic DI, but they usually have other nephrotoxic damage which is done, and creatinine may be abnormal and other urine parameters may be not abnormal, but here the patient was quite stable. Other causes, I found out whether anesthetic agents can cause DI. Yes, some anesthetic agents are implicated in DI. I don't know if this is the cause in our patient. We cannot directly point out that anesthesia is a cause, but it could be a possibility because suddenly post-operatively the patient developed DI. There are agents which have been implicated. Propofol, isoflurane have been implicated, and propofol can cause DI. So I went through the intraoperative notes. Propofol was used in our patient, and there are a few case reports, very rare, but there are still case reports which have noted that propofol can cause DI, and this is because of the inhibition of the arginine vasopressin release from the supraoptic nucleus in the hypothalamus. So this was in the animal studies which they found the mechanism. In human studies, we don't have definite studies which have seen. So we followed up this patient discharged with desmopressin nasal spray with once a day spray. She was doing very well. Her sodium were normal in the intraoperative. On skipping one dose, again the output would go up. So we continued to give daily desmopressin doses. No recovery was seen and desmopressin could not be discontinued during the stay in the hospital. Post-op OPD visit, she visited the oncology department. I got a call from Navin sir saying sodium was 128. So it had gone down, she had become hyponatremic. So she was told to skip vasopressin and refer to endocrinologist. So we were wondering whether this is a recovering DI and was it because of the anesthetic? Because anesthetic is the agent where when used, it can cause recovery post-operatively. After a few days, they can recover and further follow-up, she never turned up in endocrinology, so I don't know what is going on. I think vasopressin she has discontinued, and if she continues to be normal, it means probably sodium has become normal and she is okay. Otherwise, probably they would have come back. So still, we have to repeat the sodium when she comes next time. So the final cause, probably anesthetic-induced central DI was the diagnosis in this case, but still it's an enigma, and we have to have a further follow-up.
That was an interesting case. Any questions on this topic?
The thing is, when you have a surgery using desmopressin nasal spray, sometimes in unstable patients may not work very well. So we prefer subcutaneous vasopressin in admitted patients. 5 units can be given, and we can also assess the response, that how many hours the output is coming down. Whenever the output starts going up, we can again give a subcutaneous dose of vasopressin until the patient is stable. Once the patient starts taking orally and stable, we can use the intranasal desmopressin, because vasopressin we can titrate the frequency very well. Intranasal desmopressin, the frequency can't be titrated very well. It's preferable for stable patients rather than unstable.
Is the urine osmolality still right?
So the thing is, calculated osmolarities are not very reliable. You have to directly measure a urine osmolality, and that device is very expensive. So in our hospital, we don't directly measure the osmolality. Probably, but still, urine osmolality more than 700 rules of PI. Between 100 to 700, it's still, it could be partial DI sometimes. And less than 100, again, it is definitely suggestive here. In our patient, we were borderline, but clinically she was fitting into central DI because of the response to vasopressin and desmopressin. Probably we need to see whether it is recovering or not recovering, because that decides what is the further management. Sir, missing bright spot suggests that the arginine vasopressin, what is the bright spot which we see on T1 is the protein which is stored in the vesicles, that is the arginine vasopressin. So it means that is absent. When arginine vasopressin is not there, a posterior pituitary bright spot is not visible. With this clinical history of high urine output and response to desmopressin, I will take it still as a arginine vasopressin deficiency. The last thing, can I have the last slide please? So nowadays, the recent update in this central DI I would like to highlight is that they have been suggested to rename the diabetes insipidus as AVP-D and AVP-R. So this is a consensus which has recently come up, maybe in the last month or before that. So because of this confusion between diabetes mellitus and diabetes insipidus, so they have renamed Central DIS AVP-D, which is arginine vasopressin deficiency, it means the vasopressin is not produced, and renamed nephrogenic DIS AVP-R, which is arginine vasopressin resistance, meaning the kidney is not responding to arginine vasopressin. So probably that would relieve the confusion that diabetes insipidus and that condition supply is not needed.
Thank you. I also thank the organizers for giving me this opportunity to share this. Thank you.
Thank you, Dr. Spurti. Thank you, Dr. Spurti. Next case scenario presentation by Dr. Anupama Vaidya. To moderate this, I request Dr. Gopal, our senior consultant physician at Sahaj and Naran Hospital, to come out the dais and conduct the proceedings. And Dr. Anupama, please.
Dr. Anupama will be talking about the case of acute kidney injury in elderly women. Over to you, ma'am.
Thank you. Congratulating all my young colleagues here who have been presenting a lot of very extensively worked up cases, esoteric cases, and I'm sure all of you are it has made upon all of you so much. Now I would like to it is a very common case seen by nephrologists day in and day out, and my young colleague here, Dr. Harish, also asked me why you are presenting this case here. But I would like to make one simple take-home message across to this audience, and that is why I am presenting this case. So, hypertensive. She presented with breathlessness to the treating physician who was a regular. And she also gave history of oliguria of 2 days duration. And at examination itself, she was hypervolemic with severe breathlessness and probably edema. She gave history of, the family gave history that she was consulting an orthopedic consultant elsewhere for pain in the right foot, which was severe, so much so that she was incapacitated, she was not able to move, and she was taking NSAIDs for quite some time. And in fact, almost nearly 1 month or so, she was taking NSAIDs. She also had severe osteoarthritis of the knees, and she was taking herbal medications for the same. On examination, she was dyspneic with the BP being 140 by 80. She had severe edema in both lower limbs, and respiratory system also showed bilateral bronchi. There was a systolic murmur in the serious examination, which was the main reason why she was referred to the cardiologist initially, and there was no other findings. So in investigations also, we did not have much findings other than serum creatinine being 6.6 milligrams. Electrolytes were normal, there was mild metabolic acidosis. Calcium was relatively normal when we were correcting it for the serum albumin. And urine, there was 300 milligram per deciliter proteins with few RBCs, which could not be much significant because it was a catheterized sample. So ultrasound also was done, which showed relatively normal sized kidneys, and there the echogenicity was not much altered, grade 1 echoes were found, the corticomedullary differentiation was well preserved. So it was very clear that she had severe renal failure, and as usual, it was whether it was acute, whether it was chronic, or whether it was acute or chronic. These are the three things which we usually think as soon as we see the patient with renal failure. And since this lady had normal-sized kidneys with maintained CMD on ultrasound, it was pointing in favor of mainly acute, or maybe there was some element of chronic kidney disease, with the precipitating factor being recent NSAID use. There could be acute or chronic kidney disease as well. So her last serum creatinine was 0.9 milligrams a year ago. It was very well evident that at the time of initiation with the NSAID, serum creatinine was not asked for. So what would be the etiology? As usual, our first culprit was the NSAIDs, plus or minus alternative medications that she was on. Also, in an elderly lady who presents with acute kidney injury, we have to think of multiple myeloma or vasculitis, or since she also had significant proteinuria, we also thought whether she had any underlying glomerular disease. So the first thing is whether we should dialyze her. Definitely the answer was very simple. She was oliguric, she did not respond to diuretic infusions, so definitely we had to dialyze. But the second question, whether we should perform kidney biopsy. What are the things that we look for kidney biopsy in such a patient? We want to know whether it is acute tubular necrosis or acute interstitial nephritis. The management for this acute tubular necrosis differs from acute interstitial nephritis. Acute interstitial nephritis, we would like to go with some amount of steroids. And in addition, as already told, proteinuria was significant, so we also wanted to rule out other underlying renal conditions. So these are the points which went in favor of a kidney biopsy. But for us, the other things that we considered were the cons for the biopsy. She, at the advanced stage, the risk of bleeding in uremia itself is a significant factor for bleeding, and also because she was a hypervolemic patient, technical issues of having to place her in the prone position for the biopsy were all the other considerations. So initially we did dialysis, and after two sittings of dialysis, we subjected her to kidney biopsy. The biopsy came mostly in favor of acute tubular necrosis, but there was also an element of mild AIN. The glomerular pathology was not seen at all. The glomeruli were relatively normal. There were 3 obsolescent glomeruli, means 3 sclerosed glomeruli, which was consistent with the age of the patient. So this lady was lucky enough to have acute tubular necrosis with mild AIN. So as per the management for acute tubular necrosis, we usually continue with the hemodialysis. But in addition, because she had mild AIN, we also gave her some steroids. So after nearly 10 days of oliguria, she started making urine. And finally, after 7 sittings of dialysis and 19 days of hospital stay, she was discharged home with a creatinine of 2 mg%. She was off dialysis, and after next 10 days, she had now 0.9 mg%, which is relatively, which we must consider as a normal creatinine, because the GFR at that stage was 64 ml per minute. Post-discharge, the course was further complicated with development of deep vein thrombosis in the right femoral vein, which could be attributed to the presence of the right femoral vein dialysis catheter for some time. We had kept it for nearly 10 to 12 days, so possibly it was because of the femoral catheter, and so she had to receive oral anticoagulants for that. So you may wonder why this case has been presented here. The main reason what I'd like to make here is that this case can present to anyone and anywhere. It could be even in our own homes. When elderly people at home complain of some pain anywhere, the first response, final reflex that comes to us is take some NSAIDs. So we must understand the important adverse effect of NSAIDs, especially in the elderly with the reduced renal reserve, that these patients can have acute kidney injury. And it is not a mild acute kidney injury. It can be even up to the stage of causing severe renal failure, requiring so many days of dialysis, so many days of hospital stay, and also where patient, and in such elderly patients, if the patient has acute kidney injury, it is likely that sometimes the complete recovery of renal function is not possible, and they may have residual renal dysfunction. So there is one more important point to be remembered in elderly patients. And always you have to check serum creatinine, and not just creatinine, you also have to estimate the glomerular filtration rate. So when we check the serum creatinine, creatinine may look normal, even 1.2, 1.3 milligram percent may not be entirely normal renal functions in elderly patients, and we also have to estimate the GFR, and by estimating GFR we may come to know in frail individuals, in non-muscular individuals, women, elderly women, if the creatinine may look normal but the GFR may be low, suggesting moderate renal dysfunction. So in such cases we have to take precautions while prescribing any potentially nephrotoxic medications. And another point that I would like to make here is that even herbal medications or herbal supplements, nutraceuticals, everything can cause renal dysfunction, and severe renal dysfunction at that. So we have to exercise caution with any new drug that we may be taking or we may be giving to our patients. So, but yeah, are NSAIDs totally bad? No. They are definitely very good anti-inflammatory agents, and there are some situations where we definitely have to give anti-inflammatory agents. So the precautions that we would like to advise is that patient has to, any patients we have to check serum creatinine before giving NSAIDs. Please see that the patient is well hydrated, especially in febrile patients, dehydrated patients. We have to see that the patient is getting good hydration, then we can prescribe NSAIDs. And thirdly, we have to give as far as possible small doses for limited duration of time. Of course, when we are treating patients with the good hydration, we have to take care to see that the patient is not having cardiac disease or severe renal disease where adequate fluid intake cannot be drastically recommended. Thank you for your kind attention.
Thank you, Dr. for a simple presentation of the case. Topic is open for discussion. Creatinine 6.6. As a physician, what my listening, was it really necessary to do biopsy for this patient, or could we have treated it as a simple case of acute renal failure with NSAID? Having done ultrasound abdomen.
These are the two main issues where we have to know whether it is acute tubular necrosis only or acute interstitial nephritis. If it is an acute interstitial nephritis, we have to give steroids for some limited period of time, maybe 1 month or so. So short dose of steroids for limited period of time in acute interstitial nephritis works wonderfully well. So this is an accepted treatment protocol. So that is why we had to go ahead with the biopsy for this patient.
Do dialysis and then give do a biopsy then go for steroids?
Dialysis is because we wanted to avoid the uremic state, because uremia is a known factor which can cause bleeding, and we don't want any patient with severe renal dysfunction, maybe creatinine of 5, 6. With the protocol generally followed is that we dialyze the patient and then we give, and then we go ahead with the biopsy.
Thank you.
Thank you.
Thank you, Dr. Anupama, for your excellent presentation. I think we are 10 minutes short of time. I think we'll go to the last person who I think will present this clinical scenario in an abbreviated manner. I request Dr. Deepak CL to present this case scenario.
Very simple cases. 65-year female patient in 2018, she had a polyarthritis, but she didn't have any extra-articular symptoms. Where the rheumatoid factor was 44 and the anti-CCP was negative and the inflammatory markers were high. She first visited KMC Manipal, so since it was straightforward, she was diagnosed as RA, that is rheumatoid arthritis, and she was started on prednisolone, methotrexate and hydroxychloroquine as like everybody does the same thing. But after some time, she stopped these allopathy medicines and switched to the Ayurvedic medicines for some time. But unfortunately, her symptoms increased. This is when she visited me. When she came to me after almost 1 year, she had a symmetrical polyarthritis involving both small and large joints. She had Sika symptoms and she had some numbness and paresthesias in both the hands, sensory symptoms. She was, I thought initially because she was a diabetic patient and might be some diabetic neuropathy, so I neglected that symptom in fact actually. And no other features were there, no other extra-articular manifestations were there. But on examination, she had definitive synovitis was there, difficulty in making face, and she was in fact wheelchair bound. So even when I investigated, she had mildly elevated rheumatoid factor, but the others, everything was normal. Even since she had only polyarthritis and Sika symptoms, even I thought it is a rheumatoid arthritis and with the secondary Sjogren syndrome. So even I started the same thing because like as in the KMC Manipal what I did, I started even prednisolone tapering dose and the methotrexate and the hydroxychloroquine. But to my surprise, after 1 month, she came back with these lesions, some vesicles and some gangrenous kind of things. You can see this blackish, this thing. One can see, and some wound. This is after 1 month of starting steroids and methotrexate and the hydroxychloroquine. I was confused, even I was not knowing actually at that point of time. But after 1 month, that diffuse swelling of those hands was decreased, probably because that inflammation has come down with the steroids. And she had that skin lesions over those palmar aspect, like those vesicles and those ulcers. But she definitely had some sensory loss, which I attributed because of some diabetic neuropathy. So my disease were some, probably some infections, some might be a burn secondary to the diabetic neuropathy while cooking. That was also in my mind. And RA vasculitis was, it's rare. Usually in the lower limb, if it occurs, then it is fine. But in the upper limb, yeah, it's definitely rare. And some bulla skin lesions like pemphigoid or pemphigus, some atypical presentation might be there. But when I did the biopsy and culture came negative, but the biopsy they reported as an vaginous granulomatosis. But I was confused. Here in the description they have written some granulomas, but the typical leukocytoplastic vasculitis picture was not present in the histopathology. So I sent for the second opinion for the biopsy and I re-investigated further, like the other ANCA, the viral markers, complements, cryoglobulins, any infective endocarditis was there, and other any paraneoplastic arthropathy because she was an elderly female. But everything turned out to be negative. But after, and I continued the same things, actually the methotrexate and prednisolone tapering dose. She had applied some Ayurvedic powder, it seems, I don't know what it is. But to my surprise, that those lesions got healed up. I don't know by my treatment or some Ayurvedic treatment it got healed up. Okay, fine. After 2 months, she again, she definitely had sensory loss. And that small muscle weakness was there, which it was difficult because of diffuse hand swelling. I could not make out in the initial visits. And hand grip was there, weak. But there was no wasting of muscles. And the synovitis was disappeared with the small dose of steroid. She had bilateral ulnar thickening And but skin lesions, the other hypopigmented or hypostatic lesions were absent. This was the biopsy second opinion. You can see nice granulomas here, and you can see these are the nerve endings with a nerve thickening. This is the pacinium corpuscles actually. You can see this. This is the nerve thickening. These are the granulomas. Any nerve thickening adjacent to the granulomas, and this is a case of Hansen's actually, leprosy. So I didn't treat. I sent to the government centers. They treated, and after that all the lesions disappeared. No arthritis, nothing. Now she is not coming. This is the second case. Again, she is a 50-year-old female patient. Like she had symmetrical polyarthritis and no other systemic features. She visited family physician, diagnosed as RA because rheumatoid factor was positive. There's nothing wrong with that. Again, she was put on some Visalon and 7.5 mg of methotrexate. But this is the time after 2 months she came to me with multiple ulcers over the both hands. I show the pictures. There was a digital gangrene, there was a thickening of the skin, and there was a paresthesias again. You can see here, this is the second case, you can see this. These are very atypical for the vasculitis. These are uncommon sites actually. Here the finger itself is shortened because the digital tuft will be lost. For the palmar aspect, you can see these are very uncommon sites for the vasculitis to occur. About the palmar aspect, you can see the digital gangrenes here. And this was a thickened skin. Only for 2 months of thickened skin for a scleroderma or MCTD or other any connective tissue disease, it is very unlikely. And over the X-ray, you can see the digital tuft, like how you can see that is not there. And I thought again it is some infections because of skin thickening and the digital gangrenes, probably the scleroderma or mixed connective tissue disease is one possibility, and other vasculitis like antavasculitis. RA vasculitis is definitely rare because it's a very short duration symptom. Examination, again she had the nerve thickening and she had sensory loss. Just everything was fine. On investigation, she had a very like 1+ very the ANA was positive. This is very weak positive. DFS pattern we usually neglected. The enzyme pattern usually is a false positive pattern. Enzyme, the other inflammatory markers were high. When I repeated the rheumatoid factor, it was negative. Anti-CCP, everything was negative. And the biopsy of the skin revealed it's a borderline tubercular type of Hansen's. Again, this is the case of Hansen's, which usually presented with an arthropathy with no other symptoms. Probably when we started on methotrexate or immunosuppressants, the infection got popped up. This is the third case. She was referred to me with this ulcer, and outside the physician had done the ANCA came positive. Usually when there is a no pre-test probability, this immunological test can be many times false positive. It's okay, the ANCA by immunofluorescence was reported as an 1+ atypical pattern. This was the ulcer. And she had this swelling over the neck. She was wearing burqa. I asked to remove, and probably the outside there must, I don't know. She had definitely cervical lymphadenopathy, but the swelling, there was not much of inflammatory signs, means redness or tenderness, nothing was there. There are no other symptoms at all, like weight loss, fever, any other connective tissue disease related symptoms were absent. This was a past history. Outside, she's a patient somewhere near Sigandur. Somewhere in the Sagar, what they had done is she had an abscess exams, so they had done IND. Second time she had an abscess here, so they were done IND. Third time she had an abscess here, so again they had IND. I don't know why this abscess are recurring, but probably workup was not done. And I did an ultrasound neck, it was just reported as a cold abscess and multiple enlarged lymph nodes. I didn't go to do anything ANCA because I knew the ANCA was false positive here, and it's better to do by the ELISA rather than the IF when it comes to the ANCA. So I started on ATT. After 1 month, everything got healed. And so why the first case, First and second case, there were Hansen's, but rheumatoid factor and ANA was positive. Third case was a tuberculosis, but the ANCA was positive. Sometimes these tests can deceive us and false positive results are very high. So it's better to go by the clinical picture rather than always go by the reports. Thank you.
Thank you, Dr. Deepak. Nice presentation, especially vasculitis negates are the ones we have to look into rather than treating them with disease-modifying drugs and getting into trouble. So the topic is open for discussion. Why the first and second question had polyarthritis? But in you get polyarthritis, including small joints. With but why in Hansen they get
The infection, the lot of, one of the etiology is infections actually for polyarthritis. The lot of chronic infections, especially the Lyme's disease. They get the polyarthritis. Even HPV, HCV, HIV, Hansen's, tuberculosis.
Thank you for nice presentation. Thank the organizers for giving the opportunity to chair this session. Thank you.
Thank you, Dr. Deepak, for your wonderful presentation. Friends, you all agreement that we have come to the end of this CME program. We had longer and longest cases, and like we had in our clinical days, short cases and long cases. We almost had the longest cases today. At the outset, respected panelists, respected special invitees, and dear colleagues, we have come to the end of this CME program. I quickly request Dr. Ratnakar to present the bouquets of our panelists and speakers wherever they are sitting in order to save time. Dr. Gopal, Dr. Nischal, Dr. P.K. Pai, Dr. Rakesh M.L., Dr. Srikanth Hegde, and our esteemed speakers, Dr. Shivraj, Dr. Ganesh Gowda, Dr. Arjun N.R., Dr. Gurujan Nasar and Dr. Arvindan, Dr. Vishwanath H.M., Dr. Spurti Pai, Dr. Anupama Vaije, and Dr. Deepak Singh. Thank you. I think we have not taken much of your time. Looking forward for your valuable suggestions, guidance, and support for upcoming CME programs. Our special thanks to Mrs. Triveni Shetty and whole marketing team of Nanjappa Hospitals. Our thanks to Hotel Royal Market Program Event Manager Mr. Idris and the whole team. And finally, this entire CME program has been supported by Sun Pharma divisions, and our special thanks to Mr. Somshekar and his team for their continued support and involvement. Friends, it is time for dinner. I think you all enjoyed the scientific contents of this program rather than anything else. We will be looking forward for future CME programs. Thank you. Dr. Ratnakar, you want to share any speech? Thank you. It's dinner time. Enjoy your dinner. Thank you.